Good afternoon, everyone. We're just going to let the waiting room filter into the webinar room, and then we'll get started in just a minute. Okay. Well, good afternoon, everyone. Welcome to the June Prep webinar. My name is Jen Sperduto, and I'm joined here by my colleague, Dawn Reinhardt-Wood, and we are from the Department of Psychiatric Rehabilitation and Counseling Professions at Rutgers University, and we are with the Institute for Inpatient Psychiatric Rehabilitation. We're joined today by our presenter, Johnny Payne, who is from the Tennessee Department of Disability and Aging. And our presentation today is called Beyond Stabilization, Architecting Sustainable Support Systems for Individuals with IDD and MH in Inpatient Settings. Just as a reminder, this presentation is sponsored by the New Jersey Departments of Health and Human Services and the Rutgers Institute for Inpatient Psychiatric Rehabilitation, or IPR. Next slide, please. This is an interactive training. We encourage everyone to ask questions and participate throughout the session in the chat box. You might want to change it to everyone in their chat box. It says host and panelists. So if you just want it to come to us, your message, it will keep it at host and panelists. If you would like everyone to see your question or response or discussion, please change that to everyone. At the end of the presentation, there will be a training evaluation available that will have a copy of the slides from today in a handout version, a certificate of attendance, and the training evaluation. And as always, a recording of the webinar will be available on the IPR website tomorrow. Dawn will drop that link in the chat so you have access to it. And next slide, please. Johnny, next slide. Thanks. We are recording the webinar, so this is being recorded. Just a reminder. Next slide, please. A bit of a disclaimer for our webinar that the Psychiatric Rehabilitation Educational Program, or PrEP, is an online forum for a variety of topics relevant to inpatient psychiatric hospital staff. And while Rutgers and DBHS, DMHAS are co-sponsors of the program, the PrEP webinars are peer presented, and as such, the content is independently developed by the presenter each month. So the views and opinions expressed in the program are those of the speakers and don't necessarily reflect the views or positions of any entities they represent. Next slide. So it is my pleasure to introduce Johnny Payne, who's actually going to introduce himself. But I want to turn it over to Johnny, and thank you so much for being here with us today. And we're looking forward to a great presentation.
Thank you so much, y'all. Before we do get started here, I'm just realizing that my notes and the way that it's presenting isn't showing my notes for facilitation. And so I am going to try to mess around here to see if I can get my notes to pull up as well. So if y'all bear with me for just a second. Okay. I just want to confirm, can y'all still see the presentation full screen on your end?
Yes.
Because I'm brilliant.
Yes,
Cool.
you're good.
All right, on the fly, figuring it out. Okay, y'all, thank you so much. My name is Johnny Payne, and I am so happy to be here with y'all. You're gonna hear the word y'all out of me a lot because I'm coming at you from Tennessee, and I was raised in Georgia and made my way up to Tennessee. So. I'll say a little bit more about myself here in a second, but this presentation really is a coming together of a lot of passions for me. This is fun for me to talk about because I sincerely care about this and I sincerely believe in it. I hope that by the time that we're finished today, you might believe in it a little bit as well. So currently, I work around crisis prevention and intervention for people with MHIDD, or people who have mental health needs, challenges with co-occurring intellectual and developmental disabilities. And through my work, we use a systems change approach, and we utilize a model called the START model, which was pioneered out of the University of New Hampshire, Center for Excellence on Intellectual and Developmental Disabilities. So I'm a behavior analyst by training, and a lot of my background is around program development, both for inpatient and outpatient settings, as well as direct work therapy and all kinds of different settings. But one of my past projects from a few years back, the Blazer program at Moccasin Bend Mental Health Institute in Tennessee, won this year's IPER award. So I was really encouraged to see that thing that was planted grow into something that has created a lot of life. So I want to give a few very specific shout outs because while I did design and plant this early seedling, if you will, there are others who really kind of helped grow this and champion it beyond myself into what it is today. And so I just want to give a specific shout out to Tyson Keller, who is still at Moccasin Bend, Spring Hughes, who is still there, Ryan Beckett, who is still at Moccasin Bend, Kaylee Perletto, who is not at Moccasin Bend anymore, all who helped with the early establishment of that program. So thank you so much. So, in today's talk, we're really going to focus in on the impetus and design of the Blazer program and how approaches like these will make an impact in other settings like the state psychiatric inpatient hospital that is Moccasin Bend. So, I want to stir up some creative thinking amongst our group. So, in the chat, I would love for folks to take a second and or you can come off mute if we have that ability right now, to answer this question. You guys can put this in the chat, whatever's easier. Can you please work to picture one of the greatest successes that you have encountered in your experience working in inpatient psych? In just a short sentence, what was it? What was one of the greatest successes that you've encountered in your experience working in inpatient psych? What was it? What did it involve? Let's take a second real quick to put that in the chat. Again, you're going to need to change it to everyone in the drop-down menu. I see some folks saying, seeing change in a patient that others had given up on, seeing real people connected back with their families long-term in the community, a client intent on making a life management program after years of institutionalization, helping patients to be discharged and the patients being able to remain stable in the community, running into one of the most difficult patients that we've ever had and seeing successes, on and on and on. So I'm not going to read all of them, but please do keep an eye on the chat because there's great content here. And what I suspected would happen has happened. The common denominator here is not we saw some great decrease of length of stay measures. We saw our readmission rates go down and funding for the hospital was affected. What people are saying were the real successes are real human experiences of stability and long-term life outside of the hospital, the real human aspects of what we all really care about when it gets down to it. Um, so what I want to kind of propose is a bigger picture look at this. Across the mental health support system, readmission and long LOS is a challenge, length of stay. It does undeniably cost resources. It costs resources to inpatient programs, in every setting, and it affects the bottom line of just effective care, right? And I want to point that among this population of people, users of inpatient settings, um, there is a common denominator of intersectional vulnerabilities, and one of the biggest is experiences of people who have both mental health challenges and co-occurring intellectual developmental disabilities. Think a person who has schizoaffective disorder who also has autism, or someone who has substance abuse disorder and also a mild ID, intellectual disability. And so we're going to address a little bit of that. But the idea that I really want to build in that imagination around is this. How can we look at inpatient care as more than just a safety net, but as a launch pad? And what can we do inside of the inpatient setting to help build that as we're looking outward? So let's look at some of our objectives here today, and we'll kind of use this as a map because we will go kind of from A to B to C to D. So in the big picture, we want to first identify some foundational principles for looking at building autonomy and looking at stabilization as connected to autonomy. Then we want to look at what is MHIDD and some common support strategies, and define this large piece of the pie that is frequent readmissions and connections to long length of stay. Then we're going to make it a little more practical and talk about what are some really kind of rubber meets the road, evidence-based strategies that could address, are addressing, have in fact shown success in addressing these challenges. And then we're going to look at how can we implement some of these strategies moving forward. So, um, as a behavior analyst, we often joke that when teaching other folks, we often talk about non-examples. And so you'll often see like a behavior analyst will say, hey, here's an idea, here's a concept. Also, here is a non-concept or a non-example of that thing, for clarity's sake. So I feel bound to this. So I'm going to share a quick redacted story of a time that these concepts that we're going to talk about were not utilized and were left in want. So let's break into that story here real quick. When I was working for a state, you all know which one it is by now, Moccasin Bend State Hospital a few years back, I supported a woman in her 30s. We'll call her Brenda. It's not her name, but Brenda presented with mild ID, intellectual disability, schizophrenia, low social support, a mild history of substance abuse disorder. She had ADHD, attention deficit hyperactivity disorder, and PTSD. She had a history of readmissions, average of about 1.5 months length of stay for each of her readmissions. She had a lot of readmissions. And this day that she was in, I worked with her really closely for a few months, and she had been in about 3 months this time. She presented behaviorally stabilized, and a DC date, a discharge date was identified. We celebrated as her staff supporters. She left. And in the inpatient setting, we usually don't get to follow back up. We don't know what happens. But she DC'd, went to a hotel with some meds and a suggested follow-up plan, and we didn't hear from her for about 2 weeks. About 2 weeks later, I was exiting the hospital, and at the end of my shift, and I found her, Brenda, in the hospital lobby, sitting contentedly, kind of twirling her thumbs. And I was alarmed. I was so excited to see that she had done well. She had exited, she had DC'd, she seemed behaviorally well. And I said, "What's going on?" And she recounted the events of her DC. her discharge, the trip to the hotel, the first few nights and days, what she tried to do to make things work. I remember distinctly she said, I just felt so lost without the hospital. I couldn't remember how to find a phone number. I couldn't remember how to look up information on the internet to know where to go anywhere, how to apply for supports, how to start to find a job for myself. She said, it just felt like it would be easier to come back here where I know how to do things. And in that moment, it hit me harder than it ever did that we need to push new ideas. It ain't working. So let's drop back. People with a high length of stay, frequency of admissions, there's this common denominator, right? Intersectional vulnerabilities for them that could be complex substance abuse disorders, complex severe persistent mental illness, socioeconomic factors, lack of support systems, low functional living skills. On top of all this, a continued long-term readmission of people readmitting long length of stay, readmitting long length of stay, on and on. It actually, the evidence, the literature shows right now that this results in a continually greater reliance on inpatient support settings where we get ideas like institutionalization. It's kind of like if you've dislocated your shoulder, you're much more likely to dislocate it again the more you dislocate it. So the reliance just becomes greater and greater. So I want to introduce that we have an opportunity to move beyond measuring success by data relative to discharge, mainly like lengths of stay, rates of readmission, and instead move to more measures and data around outcomes like self-efficacy, community outreach, reduced future crises, and using evidence-based tools and assessments to get at this information. So all of this is the reason for the commissioning of the Blazer program. It's why it was said, hey guys, we gotta do something. Was to try to accomplish some of these points. So as we said, people with MHIDD, people who with mental health challenges and co-occurring intellectual developmental disabilities, Lord, we love our acronyms, represent a considerable piece of this pie of people who have long length of stay and readmission. So let's take a closer look at that and build some definition around it. So, well, I'll hit it this at 2 points. Whenever we consider this group, M8 or people with IDD, 2 pieces are contained within it. First is developmental disabilities. Um, just making this functional here, y'all. This is any kind of a disability that incurred before age 22 when a human is fundamentally finished developing or before they're finished developing. It persists throughout a person's lifetime. Now, no amount of necessarily medication or treatment is going to change that vulnerability that that person experiences. They might grow with it through gaining some skills and mitigate the challenge of it, but they're always going to have it, right? So think autism, ADHD, Prader-Willi, um, Lennox-Gastaut syndrome, Down syndrome, things like this, right? It really substantially affects functional limitations like self-care, communication, mobility, learning. Um, so autism, if I didn't say it, falls within this. The other piece of this, though, separately, is intellectual disability. Is a broad group. It often can co-occur with the former, but it doesn't have to. A person can have autism with no intellectual disability whatsoever, for example. But this includes intellectual difficulties as well as conceptual, social, practical skill deficiencies. Um, it can affect daily living tasks, communication, learning, intake of information, understanding social situations, all these kind of things, right? So that is IDD. So let me turn the page and let me attach the mental health component to this. So the full range of mental health disorders that exist in the general population can also exist for people with IDD. It is not only do mental health diagnoses exist for people with IDD, but they actually occur at a rate close to twice the typical population. So in my work that I do in Tennessee, we often say that if a person has IDD, odds are that they have some kind of mental health concern. Odds are, right? Not always, but there's about an 80% prevalence of co-occurrence of MH and IDD together. So they really people with IDD really face the same mental health disorders as others, but too often their symptoms go ignored or misdiagnosed or they're difficult to identify. You know, we're all trained into our specializations to, as a hammer looks for nails to drive in, or a screwdriver looks for screws to screw in. It's sometimes hard as a psychiatrically trained professional to be as familiar with autism as someone might be with schizophrenia. So it's understandable, but it's necessary to understand. So when these occur together, we call this dual diagnosis or MH and IDD. So I just want to say real quick a few statistics. About 50% of all people with IDD um, have some sort of psychiatric disorder compared to 27% of the general population. Symptoms of mental illness can also present differently in people with IDD. And I want to give a quick shout out to the DSM-ID-2 is a diagnostic companion manual to go alongside the DSM to help people better understand how mental disorders can present differently in IDD populations. I can answer more about that later, but um, determining really accurate diagnoses kind of comes down to overcoming some of the difficulties of understanding, and diagnostic overshadowing is a huge piece of this, which, for those of you who may not know, is the tendency of clinicians to kind of close themselves off to diagnosing other mental health conditions when a person has IDD. So you can consider that, like, a person who has autism, hand biting, which is a frequent occurrence for people with autism under distress, that they are the consideration that they are engaging in self-harm and they are self-injurious, but actually they may have a severe tooth abscess and they may be experiencing severe pain. Or that a person who has Down syndrome and an intellectual disability could never have a UTI. And so it must be behavioral. It couldn't actually be that a person with Down syndrome can engage in sexual activity. Um, so there's a lot of kind of preconceived perspectives about people with IDD that often get overshadowed and looked. So we're going to move back away from this and come back and refocus on our other piece now that we've built some knowledge. So I'm going to introduce a kind of like nesting dolls of perspectives here, like an idea within an idea, if you will. So the bigger nesting doll here is this autonomy-focused model of intervention. And this really begins to address conceptually some of the concerns we've talked about so far. And I want to give a shout out to Marie Becker from Tilburg University in the Netherlands for her work around this. And Marie passed away just a few years ago, by the way. So thank you, Marie, for your work. So I'm going to explain each one of these principles here real quick. I'm betting that the majority of our audience, some of these are familiar to you, but buckle up with me. Let's try to refresh a little bit. So strengths-based planning is a greater focus on a person's unique strengths and abilities as a driving force for their own independence building, recovery, stability, right? Like, I know myself that I am a gatherer of people. I am very relationally driven. If I use that strength to drive how I approach the problems in my life, I'm going to have simply a lot more fuel in my tank to go and do that problem solving than if I didn't use that strength in the way I approach it. Um, Next, person-centered goals is, what does recovery, satisfaction, attainability look like for me as a person, different than you? Positive psychology is another core piece of this. It is the other side of the coin. We like to say that, for example, if a person had all of the right medications, they were medically stabilized in their life, their arms weren't broken, they were functioning as a typical human does, but they don't have any positive relationships in their life. They don't have a sense of meaning or accomplishment in their life. They don't experience positive emotions in their life. Who cares if I'm taking the right medications? Who cares if my arm's not broken? What am I living for? Why do I want to take my medications if my life feels like crap? So, PERMA is this other side, and positive psychology is this other side of the coin, um, of what makes life worth living for. And then finally, trauma-informed care is really the consideration that a person's present experiences and interactions are fed by their past experiences. And without getting into it too much, basically for anyone, trauma responses play into how a person interacts with treatment and internalizes that treatment and presents behavior change long term because of those treatment efforts or doesn't. Um, so So now we're going to get into part two here, which is getting a little more practical. So let's take these concepts, this conceptual approach, and let's apply it into some more practical pieces. So uh, if that autonomy-focused intervention model is like the larger nesting egg that incorporates these ever increasingly referenced positive psychology, trauma-informed care, all of this, then the psychosocial rehabilitation approach is the smaller nesting egg fits within it. So PSR, psychosocial rehabilitation, is a service model that's utilized these concepts for a while of the autonomy-focused intervention approach, but it's typically only done in community settings. In my search, I've not been able to find pretty much anywhere that the PSR model and approach lives and thrives within the inpatient psych um, setting. So the PSR really is it's a structured approach to skill building for community living. And the goal is to increase an individual's capacity to be successful and satisfied in the environment of their choice. Um, and there's a huge emphasis here on real world application. Uh, that I often think of like place-based learning. Sorry, I'm skipping way ahead here. I often think of place-based learning in the education model, which is part of my background, or a place-based skills lab. So I'm going to start using that word more intentionally here in a second. So a great example is the AIMS Center in Chattanooga, Tennessee, where I am at. The AIMS Center is part of the Clubhouse model, which is umbrellaed within the Clubhouse International. And this is one of the greatest examples I've seen of a PSR. And I'll just say briefly, I remember the first time I visited the AIMS Center. I went for lunch at the AIMS Center. And I want to say what I saw there. Um, Aside from kind of all the friendly faces and warm welcomes that I got from Clubhouse attendees, which they call members, um, I noticed that lunch took a long time. I noticed that in the preparation of the meal and the serving of the meal and the cleaning up of everything and all the interactions, it took a long time. And I realized that that was actually very much on purpose. it was supposed to take a long time because the members themselves selected the meals, shopped for the groceries, looked at the budget and decided what they could afford, prepared the food, served the food, cleaned everything up, interacted with each other in a community setting, and carefully followed food safety guidelines. And this was all facilitated by staff facilitators, but facilitators didn't get in there and try to get it done faster. They coached the person to go through themselves and do the place-based lab skill learning to get it all done. And the AIM Center also has other, and a lot of Clubhouse models, other applications of this same kind of practice. The AIM Center, for example, had a newscast. They commissioned art projects from the community. They had a job training center hosted by other members helping with job training. This is almost kind of like a Montessori approach to this, right? The housing department was run alongside members to help other members. It's really cool. So in all of this, efficiency was not the objective. Accessibility and growth of the contributors were the goal. So then this brings me into the Blazer program. It's where it all came from. I was really enamored by the AIM Center and the PSR model, and I was seeing this length of stay challenge, and our hospital um, had kind of brought up, what can we do? And so this is where it all kind of came together. We did tours of the AIM Center, really interviewed their staff, tried to understand what was the coming together of all of this for them. And so how can we bring a skills lab into the inpatient setting that mocked out hospital living to act as a ramp or a launch pad into stable community living? So how can we create this inside? So the Blazer program is a lot to describe. But fundamentally, there was a group of about 10 patients and two staff facilitators. And in the day to day, instead of attending normal hospital programming, they would instead go to the Blazer program, which was a physical space where they exercised day-to-day life in a skills lab setting. They attend the treatment team, by the way. They went to their treatment teams as those things were scheduled, but alternatively, they come to Blazer program. And in everything that they did, they acted as a small community that worked to communicate together, live together, plan, problem solve, create together, as if they might in a group home or in a home with family and friends after discharge. We were on ramping them while they were inside of the hospital, but not just, hey, come and sit in my therapy group and let's talk about making sandwiches together. But like, no, let's actually go do all of the pieces leading up to making lunch together or any of these other pieces. Um, I'm happy to take more questions later about the Blazer program and what some of those programming aspects were. But for the sake of time, I just want to say there, the Blazer program had a unique distinction, has a unique distinction that since they have started taking in participants, they have a 100% success rate. There's no one who has been a part of the Blazer program and has graduated the Blazer program who has ever come back to Moccasin Bend. And I would love other data to see if there were any other challenges, but I think those of you who know how regionally patients can have reoccurring admissions within a geographic area, I think that's pretty tremendous. And so I just want to point out a few of the quotes here that y'all see on the slide. And the one that stands out to me the most was at the top, a person who had a lot of readmissions. I remember him saying, before the Blazer program, I had not made a meal for myself or anyone else in almost 4 years. how do we discharge that person? How do we expect that person to do well if we're not giving them platform to practice real human life um, somewhere? So I want to break down two significant strategies that are utilized in the Blazer program and many other PSRs, which fundamentally can be replicated in the inpatient psych setting across the country. Um, One is live living skills simulation, and the other is community reentry groups. So let's hit the live living skills first. Hmm. Rationale behind this is that it's building confidence in using a safe practice. We made lunch. We used knives. We used heat sources. We put patients in potentially situations where potentially someone could um, get hurt. There's a bit of risk, calculated risk, but our knives were nylon knives. They were safety knives. Our stove was an induction heating stove. Our staff were specially trained. But there's an element of I'm putting something on the line here, right? It's not overly sanitized. And this is a concept of the skills lab, having the physical space, role playing these scenarios out, um, and in a way that has almost a bit of risk. If I don't budget and go grocery shopping, do I get to exercise my choice in what I'm going to eat for the next 2 weeks? But if I put my skin in the game, I get to participate in choice, um, a fundamental human experience, the feedback, um, and something someone said here recently really stood out to me that so much of what we do as caregivers and advocates of other people is preparing the path for the person. But instead, how can we prepare the person for the path? Um, and so I want to point at using assessments to measure things like skills and self-efficacy. And so in the skills lab, this was one tool that we used was a functional skills assessment. And at the beginning of a patient's admission to the Blazer program, they would get a baseline skills assessment measure, and then every 2 weeks we would do a new measure of this evidence-based behavior analytic assessment to determine how are they growing, how are they showing new self-efficacy using these parameters. And this is searchable. You can go look this up on Google, and you can find examples of this assessment to use in your own setting. The second strategy is community reentry groups. And this really, for our patients, we had found really reduced anxiety, built social connection. It really kind of helped people feel human within a sanitized clinical container that often does not look anything like the real world. Um, and we, in doing this, it was, if you ever heard of the RAP plan, the Wellness Recovery Action Plan, this is really like living out the RAP plan together intentionally as a community. Um, and being careful not to spend too much time on this, I'm happy to answer more questions later. This is kind of an example of the of it played out. Every morning, at the beginning of the day, and every evening, we would get together as a community of um, of participants, and we would help the participants facilitate a discussion amongst themselves of what was something that happened today that was useful, what's something we learned today in our practice that can help us into the future. How can I implement the things that I've actually practiced today into my own personal well-being, my RAP plan, my whatever, right? And so building rhythms and practicing rhythms that can transition into group home, family home, community living, job setting, whatever, and not just having a one-off group about it, but actually practicing it, building those rhythms together. in a real community setting. So I want to take a second to step back, all of us together, and I want us to take a quick 2 minute break. I want to invite you to take a step back and consider how could one of these strategies that we have talked about apply in your setting? How could one of these strategies that we've talked about really be applied in your setting? I'm actually going to go ahead and put about 2 minutes on my clock, and I'm going to go on mute. What I'd love for us to do is when we come back in about 2 minutes, I'd love for us to pump some of this into the chat. Some of your takeaways, maybe a sentence about how can we apply one of these strategies or some of these strategies into your own setting. So I'm going to go ahead and put that time on the clock right now, and I will pop this question back into the chat for clarity, and I'll put my time on the clock, and I'll see y'all in about 2 minutes. I really appreciate you. All right, everybody. That's about 2 minutes. So let's go ahead and toss this into the chat. I see that Tom and Michelle have already put a couple of things in. But again, if I've not said it enough, how can you use these strategies in your setting? Toss that in the chat. Make sure you're doing it to everyone and not just chat and the panelists. While we are typing that, I will read a couple of these marvelous comments and say Tom says, use progressive empowerment if safety is too much of a concern, like match autonomy to risk. Michelle says, transfer of, oh gosh, everybody's putting it in right now. Great job, everybody. Can I just go up and down? Yeah, all right, cool. Transfer of learning is my role. So transferring what we have learned today to others doing direct care. That's great, Michelle. Um, cool. And comment about MHIDD. Awesome, Michelle. Deb Anderson, I'd love to use twice daily house meetings into our program. Very cool. Love that. Deborah, our facility is a secure lock facility, so it's very limiting. However, I could bring in grocery store ads and give the patients a pretend budget for them to buy groceries. I could also bring in for rent ads and help them see what kind of living spaces. I love it. We're building imagination, right? We spend so much time inside of the walls of a particular rhythm and set of environmental expectations. How could I begin to imagine a world outside of this? So Deborah, really, really great considerations. Um, I'll take one more, maybe. All right. Wait, I think I have four more down here. We see a lot of these strategies implemented in the occupational therapy groups in our setting. They have the opportunity to do and practice and plan to be fully immersed. That's awesome, Colleen. Thank you. All right. So let's move on from here, and we're going to begin to close up. So this blueprint of how do we implement some of these things. So I'm just going to go over this very, very quickly. What made this truly possible, given the challenge of starting a program, a pretty comprehensive program or initiative in a state psych hospital, especially given some of the inherent risks, ain't easy. So how do we do this? For one, we had to really lay out a very clear plan and answer all of the questions that we could up front, then begin to build stakeholders around it, right? So once we kind of anticipated the challenges, we worked to build a network around the idea. And then overcoming the barriers. So there were kind of three big pieces: staff resistance, limited resources, and just systematic inertia, right? Like we've always done this way. So for staff resistance, we really kind of tried to build alignment. We're focusing on shared goals here. I can say more about this later. And for limited resources and funding, starting it as small as we can. It was about 10 patients whenever I left, but when we started, it was like two or three. And then we built a case of evidence by starting small, risk small, gain small, right? And then for we've always done it this way, we had to show data. We had to share those success stories. And I'll tell you what, the quotes from the patients, that really sunk in for folks. Those really hit people hard. And so creating champions within the work that were almost like key holders within the larger system and using that to help us kind of move things forward. So another piece about this was creating like replicable data and building out standard operating procedures for the program that were saturated amongst everyone involved in the program. That if we had staff turnover, if there's a funding change, if let's say COVID happened, we had standard operating procedures that spelled out how we did absolutely anything in the program. And so that lived on past just us, right? So, key takeaways. One, we got to begin to imagine success beyond just stabilization. Two, we got some PSR practical strategies that could be implemented, and I hope you're setting. And three, sustainability really requires strategic engagement and planning, very intentional pieces. I want to share some of these resources for folks to look into. The NADD is and the National MHIDD National Training Institute are a great resource for people who have co-occurring MH and IDD. Clubhouse International is a great example of PSRs to look at, and the National Center for START Services is um, who is the model that I use in my work in Tennessee, and I'm happy to talk about that at a different time. But I want to open up since we've got a little less than 10 minutes still left for any questions and answers. I'd love to kind of open up some more of this. And Jen, if y'all want to help
Sure.
field any chat or whatever your process is at this point, I appreciate it.
Yeah, so I don't know if you can see it on your end, but there was a question that came into the Q&A and not the chat box from Nicole says, have you seen success stories in the program such as the Blazer program when they are on conservatorship, meaning they are deemed gravely disabled? We are seeing direct admins from the community to California state hospitals that are under LPS and DD/IDD.
I mean, yeah, I I I can remember in my time with Blazer that half to two-thirds of all of the participants had conservators or some sort of decision-making support, from rep payee to some measures of power of conservatorship. And I think, part of the stakeholders that we were careful to draw alignment with internally were our director of social work and all of our social workers. So they knew that when this person was coming for discharge from the hospital, not necessarily graduation from Blazer only, but discharge, that we are making sure that the decision maker is very familiar with what the Blazer program is and working to accomplish. And we're trying to translate that and build that bridge between our work and that decision maker, which I mean didn't work all the time, but I think worked well enough to stave off readmissions for our graduates. I'd love to answer any other questions, y'all, if you've got any.
It looks like there's some coming in the chat.
Okay. All right. There y'all might look a little bit further up in the chat to see if there's any more, but I see one from Barbara that I'd love to answer. Um, she says, did you encounter any resistance to keeping patients beyond when they are sufficiently stable enough to be discharged? Were patients able to be voluntary status, for example, to continue? Inpatient slots are so limited, waiting lists, civil rights issues. How were you successful in addressing these things? I think it was some give and take. It wasn't perfect all the time, right? But I think we really leaned on the relationship that we had with the director of social work and some of our key social workers who, um, our director of social work would make sure were assigned to Blazer program participants. Because they were able to really speak to and understand the ins and outs of what we were trying to do. And so whenever we were getting close to discharge or graduating, as we say, the Blazer program, we would try to give that early heads up to social work staff and attend the treatment team for that person, so that everyone is really kind of on the same page of creating that ramp off of the ramp of the Blazer program. And so we wanted to narrow that window as much as we could so that we line up graduation with discharge and all that. But it was very rare that someone, I think in my time, it might have happened two or three times where a person graduated from Blazer, went back into the typical rhythms of the hospital, and then within a couple of weeks discharged from the hospital.
Thank you. Any other questions coming into the chat?
Bef While we wait for just a second, I do just want to say, everyone, uh, I I would I really believe in this. I would love to be a resource if it's at all helpful, and I'd be happy to take a short conversation sometime if it might help empower you and your setting in some way to consider any of these ideas. So I'd love to avail myself, but Secret Blazer program was not ran. By the treatment team members. Okay, so Nicole says, if I'm understanding correctly, the Blazer program was not ran by the treatment team members. Correct. It is a separate resource inside an inpatient hospital. Correct. It was run by the therapy department of the state hospital. Yeah. So it was made up of various different recreation therapists, different MSW and LCSW candidates, all sorts of different modalities. Was it residential? It was residential in the thought that it existed within an inpatient psych hospital, but no, it was not a place where patients came and slept. It was a kitchen with a dining room, a small computer lab, living room. We had a small video studio where we created a newscast each week and then presented it back to the larger hospital about weather, upcoming events, community events, strategies for discharge and community reentry. Um, we went out into the community once a week and volunteered at Habitat for Humanity, separately a local farm, and then separately a local store, and rotated those vocational outings. We made all of our meals together, grocery shop together, on and on and on. I mean, we lived a group home life inside of the psych hospital. And then everyone went back to bed on their units. But I appreciate y'all. So thank you for your time.
Well, thank you. If there's no more questions, I just wanted to let everyone know that there's a training evaluation that Dawn posted the link to. And in that training evaluation, as I mentioned, you can access the slides from today's presentation. And there's some resources and links that Johnny put in there. There's also the recording of this webinar will be available tomorrow on our website. If you don't get a chance to access the training evaluation today, I know a lot of us, some of you leave at 4 o'clock. So if you don't get a chance to do that today, expect to see a follow-up email tomorrow morning from us that will include the links for the training evaluation and the direct site to access the recording. And also a link, if you're interested in presenting a prep webinar in the future, there's a link to do that. You can submit your proposal um, to present. I will warn you, though, that the website is currently experiencing some outages on the Rutgers side. So if you don't get in right away, please keep trying. You'll be able to get in hopefully tomorrow if it's not back up and running in a couple hours. We realized this right before the webinar, of course, that the website that we were posting links to over and over again was getting an error message. So hopefully that'll be fixed soon. But you can access the training evaluation without going to the website. But look for an email from us tomorrow morning with all the extra information. So I want to take this opportunity to thank you, Johnny, for being here with us today and a great presentation. It's so important. And I wanted to also let everyone know that in July, prep will be on summer break. So we will not be having a presentation in July, but we will see you again in August. So hope everyone has a great July summer break, and we'll see you again in August. Take care, everybody.
Thanks, Joe.
Bye-bye.